Over the past few years, certainly throughout the pandemic, I have been interviewing people across the world. I like to look at all aspects of science, anything that is progressive, moving forward, innovative thoughts. And one of the biggest areas that is going to touch every single one of us in some way, shape, or form is that of artificial intelligence. Now, some people, when they hear that, may immediately start rolling their eyes. But what I'm going to be doing today is looking at its role in relation to healthcare. Now, this is very, very important because I suspect that we are going to see an exceptionally rapid transition in the way how health is delivered. It's relevant to you as a consumer. It's relevant to clinicians, doctors, managers, everyone who is involved in healthcare. And as a privilege, I have got one of the top experts across the world to speak with me today. And so, without further ado, let's introduce to the stage Dr. Robert Pearl, who is based in California, aren't you, Robert?
I am. It's a pleasure to be here today and be speaking on both sides of the Atlantic Ocean.
Excellent. So I'll ask you if you can just do a general introduction to everybody about who you are and what is it that you bring with regards to AI.
I am a plastic surgeon by training. I went to Yale and did my residency at Stanford. I focused on children with cleft lip and cleft palate. And then across my career, I took on administrative roles and I became the CEO in Kaiser Permanente, which takes care of 12 million Americans on across the United States, but predominantly on the East and West Coast. And then I decided to spread the message more broadly. And after 18 years, left the position. And right now, I'm a professor at the Stanford University School of Medicine, the Stanford University School of Business. I also keynote about 40, 50 conferences a year in the United States and around the globe. I write for Forbes. I have a podcast called Fixing Healthcare that comes out every Tuesday night. I also have a website, robertpearlmd.com. And my most recent book is called ChatGPT MD, How AI-Empowered Patients and Doctors Can Take Back Control of Medicine, with all profits going to Doctors Without Borders, a wonderful global charity.
Wow. Now listen, even I'm impressed with that, Robert. That is impressive. Wow. My audience, remember, this is a celebrity moment. I've got the Robert with me. Now, tell me something, Robert. When we talk about your background with regards to plastic surgery, it caught my attention that you said cleft palate. Can you just simply explain that to the audience and tell us what made you go? Why didn't you just do breast constructions? You could have done so many things with plastic surgery.
Well, you have to actually start when I was in college. I went there early. I was just 17 when I started, and I wanted to be a university professor. And in my freshman year, the individual who was my mentor, who ended up being the chairman at Reed College in the United States, a very prestigious spot, didn't get tenure. Not because he wasn't brilliant. He was absolutely brilliant, but because of his politics. And as hard as it's to believe, I decided to go into medicine at that point because I wanted something that was going to be non-political. Retrospect, obviously, completely absurd. And I went to Stanford. I actually went to become a heart surgeon with a physician called Norm Shumway. He was the first transplant surgeon in the United States, followed a surgeon in South Africa, Christian Bernard. And I loved being a heart surgeon. And then I had a chance to do a rotation on plastic surgery. And Don Lab, who was the chairman of the department, took me to another country where we did mission work, operating 12 hours a day, case after case after case. And I came home with more energy and more invigoration than I ever had in my life. This notion of helping people, changing the human life in an hour, hour and a half of time, just thrilled me. And so I switched across into plastic surgery in order to fix children with cleft lip and cleft palate, which I still do to today. I was in the Philippines last year doing my 15th mission trip.
Wow. It does say a lot about you, Robert, the fact that you have that kind of heart and that kind of focus. And it's a credit. I think it's important for people to remember that for many clinicians, many doctors, there is a passion that is driving them to serve and to help people. And I think that came across beautifully there. So tell me now, as we shift into that question about artificial intelligence, one of the basic points is that a lot of people discount it because it's just AI. It's been around forever. How do you make the differentiation between what is happening now and what was happening in the past?
I too was one of those skeptics, although I've been involved in technology actually since high school. I didn't see, and I'm going to use the word narrow AI because these were the tools designed around the year 2000. It was a time when we shifted the architecture and moved it into a biological way, the same way the human brain is organized. We look at what's called neural nets, multiple levels of thinking that interconnect with each other. And the way a narrow AI tool is constructed is that two data sets are given to the application, which it then compares. You might take 5,000 mammograms that show cancer and 5,000 mammograms that are normal or only have benign disease. And then you ask the application using programming technique to compare the two, and it finds maybe 50 or 60 slight differences between the two, many of which, by the way, the human eye can't see and the human brain can't comprehend. And then it comes in with probability factors for each, and then you can test it. And you can see that the tools are able to perform, in this case, 10% better than humans. And there are about 1,000 of these applications approved by the FDA in the United States. The challenge with them are twofold. Number one, the tools are narrow. Even though you did a study on mammogram, the ribs or the chest or the lungs that are adjacent to the breast, it can't read any x-rays of that particular area. But the second and more significant one is the way a narrow AI tool works is it magnifies slight differences between databases. And it's why I was a skeptic of Watson and a bunch of other tools that were promised to be able to revolutionize healthcare, because the data on which they were trained, this is data around the electronic health record, was just not accurate enough. You have a pain that your doctor says is 5 out of 10, and I have a pain that my doctor says is 6 out of 10. Who has more pain? Totally subjective, and that's why that data has never been able to be translated into clinical practice.
So I think this is such an important point because, as you said, certainly in terms of radiology, I'm thinking of different ways that it can look at the arteries and so on, and the details that it can bring up, the mammograms, even some of the skin associated tools in terms of looking at query cancers or moles and so on. So it is quite limited, and we have seen this work. And so therefore, many people are thinking to themselves, hey, come on, how much better is that going to get? What else can you do to it to make it better? But this AI that is now here, and my analogy to it, and you can tell me if I'm wrong, when I think of AI now, the AI that we're using, I compare it to Jack and the Beanstalk. I think that this thing is so phenomenal that I don't even know how we came up with it. It's like we found a seed of something, planted it, and this is growing in ways that we have no idea where and what it can do. How do you describe that compared to this narrow AI that you said?
I think we should stop talking about AI for exactly the reason you said. It's not descriptive. And we should call this generative AI. I call the book ChatGPT MD. I have no relationship with OpenAI, just so listeners are aware of that. But I like GPT MD. It just flows nicely as a book title. and it's completely designed differently. What it does is it takes all of the information that exists, everything on the internet, every medical textbook, every published journal article, every piece of information that can be found, and using that, it gets the P pre-trained. Then it gets transformed. Information that comes from a peer-reviewed journal is seen as more valuable than one that is just published by an individual clinician. Information that comes from an academic institution is going to be more valuable than information that came just out of maybe a community practice. It's not that the latter is not going to be okay. It's just that has to establish this relationship. And then the G is that it generates an answer to any question you can ask. You can paint a picture that looks like a Rembrandt, even though you've never taken an art course. You can compose a song, sounds like Drake in the Weekend, even though you've never played an instrument. You can program a computer, by the way, as well as the average programmer. And in medicine, it's going to allow you to make diagnoses. We've talked for a long time about what's called artificial general intelligence, AGI. This is the time when the applications, the technological tools are as good as humans. And we are about to enter that. Sam Altman, the CEO of OpenAI, said it's 2 years away. The CEO of Anthropic said 3 years. The founder of Google, Sergey Brin, said 4 years. It's somewhere in the next 5 years. And when that day comes, and it's coming soon, medicine will have to change, because now technology will be a colleague, not something that is subservient or something simply used for administrative tasks.
I think sometimes I say to people, just go back to about 2008, 2009, when the iPhone first came out. And think about where we are now. And not even now, by the time we had hit 10 years of using that kind of technology, it had completely changed the world. So say, for instance, in the UK, the London, to be a cabbie, you had to actually study a map of London, and they knew it inside. And you have Uber, where you could come from anywhere, not know London, and be able to compete better than those cab drivers. Is it going to be that kind of dramatic, seismic change that will occur in healthcare?
I love your story, and it reminds me that when I published my first book called Mistreated, prior to that, I tell the story in Mistreated about my dad, who in 2007, when the iPhone first came out, called me. And he said, Robbie, you love technology. I got to tell you, I just bought an iPhone. I said, Dad, that's amazing. What are you going to do with your iPhone? And he said, I'm going to lock it in the trunk of my car. And if I should get into an accident, I can call for help. That was the most that he could come up with. And he was, as you say, ahead of most people at the time. The answer is yes, and the and is that the growth in ChatGPT and all of the what's called large language models, it could be Gemini from Google, or it could be Claude from Anthropic, they are doubling in power every year. The iPhone didn't double in power every year. And doubling in power every year means that by 5 years from now, it's going to be 32 times more powerful than today. In 10 years, it'll be 1,000 times more powerful. That's the equivalent of your car going as fast as an airplane in 5 years and a rocket ship in 10 years. And so compared to the iPhone, yes, it's going to have the upward trajectory of use cases that we saw, but the ones that will be here in 5 years are almost unimaginable to the average person today.
I wanted to capture an idea as you were talking there, and as you were making reference to the iPhone and the trajectory and so on. I liken it to a tsunami of change. It's like being on a beach, and suddenly you see the water going out, and you realize that a tsunami is coming. Some people may stand and stare, a few people may try and run back, but this is almost like grabbing your surfboard and rushing towards the water to get on top of the wave so you can surf it. Is that the kind of approach that is needed now from healthcare?
Absolutely. You know, in the United States today, doctors are struggling. And they're struggling because as the economic pressures grow in this country, what's happening is that the payers, we're talking often about the government as well as the business payers, the commercial payers, are just cutting back and cutting back and cutting back. And so they're having to see more patients every day. They're seeing patients every 17 minutes. They're having lack of fulfillment, growing dissatisfaction. We call it burnout. And from what I understand, in Great Britain, a similar thing is happening with the National Health Service. It too is struggling by the economics of medicine, and is cascading down both to the providers and the recipients of care. Anyone who believes that staying on the current path, and again, I'll speak more about the United States. I feel more comfortable, questioning and criticizing my own country. But again, you can correct me. I think it's just as true in Great Britain, is deceiving themselves. Today's problems are only going to get worse. The pressures to bring down healthcare costs, to address national deficits, to be able to try to solve the economic and financial difficulties of modern medicine are only going to grow in these countries. And my belief is that if we keep restricting and constricting, we're just going to aggravate the problems. What we need to do is we need to be able to start to shift our mentality towards keeping people healthy. And we don't have a tool to do that. Sure, we can tell you eat better and exercise and get your preventive screenings, but we really don't have the tools to do that effectively in the time that exists. And in every industry for millennia, you see that technology comes in and helps the human to accomplish that. In the United States, half of all Americans at the turn of the century, turn of the 1900s into the 1800s to the 1900s, half of the people were farmers. Today, it's less than 5%, growing far more crops than existed then. And what's the difference? The tractor and other pieces of technology. Same thing, I believe, will apply in medicine as applies in steel production or farming or really any other industry across time.
I'm thinking about what was just recently done in the UK, and I have to give them credit for doing this, even though some people may argue about the ethics of it. But they took 57 million data points, health records, anonymized them, so it doesn't know who they are. But granted, AI is pretty good, so maybe if it really wanted to, it could work it out. But it then takes that, throws it in the mix, and just says, work this out. Based on the speed and the growth of AI, what do you think it's going to do with that kind of data?
This is a great example. And what you're talking about is why I'm very optimistic about generative AI into the future. Most industries and most of applications of generative AI, they're running out of data to train the model on. We discard most of our data. If you're put in a hospital at the bedside, there are monitors. They generate what's called a terabyte of data. That's 10 with 14 zeros after it. And 97% of it we throw away. And rather than comparing data sets, which is what the narrow AI tool did, the generative AI tool is going to take it and it's going to learn from those experiences the same way when we train residents to become practicing clinicians. They watch the clinician practicing and they learn to be able to emulate it. And having learned that, they can look at the outcomes. And in this situation, learn from the best. And that's what's going to be very different. This technology is going to be able to look at, as you say, 57 million different records, looking at the outcomes, finding things, It was really interesting in the COVID period. As you know, people didn't want to really come in and get the diagnostic or the screening they needed because they didn't want to be around patients with COVID. So the number of mammograms that were done in the organization that I led dropped significantly. COVID ends, and now everyone wants to come in, and you only have a certain number of machines, and so you've got to prioritize them. How do you prioritize them? Well, you can prioritize them on a lot of information, but what we did instead is we used generative AI, because now we're past the release by OpenAI, to look at the mammograms that have been done before and figure out who was at greatest risk. Now think about that. How do we figure it out? We base it on age, or maybe we base it on family history. This could actually look at the mammograms and see subtle changes. They weren't yet cancer, but they could have been. And now you can focus on those 10% of people. That's remarkable. Take chronic disease. According to the CDC in the United States, if we could effectively control chronic disease, as well as the best medical groups and health systems accomplish today, we would eliminate 30 to 50% of heart attacks, strokes, kidney failures, and cancers. And now start to ask yourself, what would happen in Great Britain? What would happen in the United States if 30 to 50% of heart attacks, strokes, cancers, and kidney failures no longer happened? What would happen to the health of the population? And what would happen to medical costs? They would plummet. And that is the opportunity that we have. It's not that we couldn't do it before. When I was the CEO in Kaiser Permanente, we led the United States in quality outcomes, but we used hundreds of very expensive nurses and pharmacists to accomplish it. You just couldn't afford to do all the things you would like to do. And we invested a lot because of how we were paid through a capitated system, prepaid care of system of reimbursement. Generative AI can do that across a weekend, as you say, for 57 million people. This is a remarkable opportunity that we've just never had. And all of a sudden it's upon us. The challenge is going to be, how do we embrace it as as patients and as a nation?
Let me challenge you on this here, because this is an important question. And as you are speaking and the passion is coming through, a lot of clinicians are going to be thinking, oh no, oh no, oh no. Because what they're thinking is this. I remembered years ago thinking to myself, wouldn't it be great if I could figure out type 2 diabetes and solve it? And then I realized that if I solve type 2 diabetes, do you know how many jobs would be decimated in the health service just by that one condition? So when you think of it that way, medical schools are growing, more doctors are being trained, and what you are saying is scaring the daylights out of many people who are coming through. What do you say to them?
I love this question, and it's actually an article is being published in Forbes next week exactly on this topic, why I don't believe that actually we should be scared of this. Now, why do I say that? Well, there's a lot of different reasons for it. One reason is we have a shortage of clinicians in the United States, and I think as well as in Great Britain. So despite the fact that we're training people, the population is aging faster, getting chronic disease more often. But the more important part is we've thought about the cost of medical care absolutely wrong. The cost of medical care is not, or the solution to the cost of medical care is not to have fewer clinicians. They're actually a small part of the total expense. It's to have fewer diseases. And now, yes, a country could say, look, we don't need as many of you because there's not as much demand. That's a fee-for-service mentality. Or we can say, look, we're already spending, and again, I'll use US dollars, $5 trillion a year. It's projected to rise by 6% a year. It's going to go up theoretically $300,000 next year. What happens if we just hold it steady for the next 5 years? Now, in today's system, without a tool to accomplish that, that would be devastating. You couldn't run your office. Your costs are going up and your demand hasn't changed. But in a prepaid, pay for value type capitated system, now it's wonderful. Because if I can lower by 30 to 50% the likelihood that my patients are going to have a serious illness, and I'm going to be paid at the same amount of money, I've just increased my income. And I also believe that there will always be a role for humans. And I think of that for multiple reasons. First of all, I think it's going to be a long time till this technology can do everything that doctors do, particularly for patients who have serious illness, life-threatening illnesses, problems with cancer. These are the kind of conversations that theoretically can be done by an application, but people are going to want to talk to a human. And there's something about the human touch. No, I think we need to start with the challenges today. I see you in the office, you have hypertension, I prescribe a medication for you, and what do I say? I'll see you back in 4 months. You come back in 4 months, your blood pressure is still elevated. What do I say? White coat syndrome, come back in 4 more months. Imagine if I definitively knew at month 1 that my medication was not sufficient. And now I could change that medication and better control your hypertension or your diabetes, or I could know that you're about to have a heart failure exacerbation and be in the ER in a few days. Now I can intervene more rapidly. I see you have a mental health problem and you're depressed with some anxiety. I'm worried about potential suicidal ideation. And what do? I see you in 2 weeks. What goes on in between? We don't know. Or look at the hospital. I'm a very healthy kind of guy, but I'm also a really aggressive athlete and skier. And I've come off a bunch of cliffs and broken my leg and my arm and a bunch of other things. So I've been in hospitals. Nurse comes by at 8 a.m. She comes back at noon. What happened in those 4 hours? No one knows. There were monitors. It knew, but no one actually has that data. And what we know is that if a patient is going to deteriorate in a medical surgical unit and go to the ICU, that we could predict that in advance. And if you can avoid that, you lower the mortality rate by a factor of 4. And obviously you save the costs involved. The opportunities to use this to expand what we do with the goal of improved health and lower costs, that's really the goal that we're talking about when we're looking at the application of generative AI.
As you were talking there, I was just starting to let my mind float. And what came to my mind is that I thought to myself, even what you're saying is just the tip of the iceberg. This is a technology that is so powerful that, how do I say this? I'm trying to see if I can find a way to encompass the thought that I have. Where we practice or where we operate at the moment, the level we're operating on is almost so basic that AI can come into that space and do many things better than us. But you are right. There are things that the human mind, the human spirit, the human ideals can do that are so far beyond what we're doing that AI allows us, frees us to do those things that normally we don't have a chance to do. And I think that when you actually reflect on it and you think about the health of the population, you're right. We are drifting to a point now where people could just be healthy all the way over to 100 years. What the heck would we do? How would that change the way how the world operates if suddenly we are just dealing with disease at such a comprehensive level? That's almost frightening, not frightening, but it's almost so big you can't quite conceptualize it.
I would say we need to rephrase a little bit of what you said. The first thing is that the data says, I'm not sure 100's the right number, but it says that we could, through better management of things like chronic disease, extend our lives for 7 years, of which 6 of them would be healthy years. So now we're starting to look at a very different society. where we have people who can be productive, who today are infirmed as a consequence of the disease. You know, when I think back to what it must have been like to practice 50 years ago, we're talking maybe, I don't know, 1970s or so. Most of the problems that doctors saw at that time were acute problems. You broke your arm and we reduced the fracture and casted you. You had pneumonia, we prescribed an antibiotic for you. You had right lower quadrant pain and we diagnosed appendicitis and took it out. Chronic disease didn't really exist at that time. Today, it's 70% of the visits to clinicians. It's at least 70% of the cost, if you include its complications, that sit there. And we still have an acute care model, one based upon the doctor's office. I often ask myself, why is it that clinicians are struggling around the globe? And again, I'll use the American data, 50, 60% of clinicians saying that they're burned out. It's because, and you started this early in this podcast, they're mission-driven people. They go home at night unfulfilled because there is no way they can do everything they need to do. According to a study that was done, if primary care doctors did everything that was recommended, it would take 27 hours a day. It can't be done. We're asking people to do an impossible task. We're forcing them to cut corners. We're leaving them exhausted and unfulfilled at night, not because they don't work hard or smart or do anything else. It's just the task has grown. You walk into my office and you have appendicitis. I'll see you pre-op, maybe twice post-op, and I'll do an hour procedure. As soon as you walk in with diabetes, I have to schedule 200 visits 4 times a year for the next 50 years of your life. We need help. And the help isn't going to come with a lot of money because none of the governments or none of the businesses have the resources. That's the truth. But it can come through technology, particularly technology that is inexpensive. I mean, look at it right now. There are free versions of ChatGPT. There's free versions of what's called Llama, the tool from Meta. There's free versions from DeepSeek coming out of China. We're looking at tools that are either free today. There's a free version of ChatGPT. And if you want to get the really high-end cost, it's not the cost of a Ferrari or a Porsche or a Bentley, I guess, in Great Britain. It's $20 a month, an expense that almost every family can do. It's 2 to 3 lattes a month that you can cut back on and have access. This is a very accessible tool that all people in every country can have, whether the cost is provided by the government for the poorer segments or by people overall or healthcare providers overall for the wealthier segments.
It can be overwhelming for people. I'm in kind of the space of technology, a lot of it because my brother works with a lot of technology. And I remember him saying about 2.5 months ago, Runway is the next big technology for video enhancement. And he was saying he was waiting years for the technology to reach this point where he could implement some ideas in real world. Within 2 months, Google produced VO3, which blew it out the water. I mean, the speed that this is going at is almost too overwhelming for people. How do they keep up?
You're absolutely right. When I wrote the book, ChatGPT MD, the information available to me was 18 months out of date. Today, it's up to date. When I wrote the book, I had to actually type into it all the information. Now it's multimodal with images and with voice. When I wrote the book, I predicted it would be 10 years for AGI to come. Now it's less than 5. I predicted that the first time that we would have tools that would be reliable for patients to use without having clinician oversight was a decade away. Now we already have mental health tools. You're right, the pace is remarkable. But I think the biggest evolution is really not how we can talk about this some, because there's so many ways in which clinicians can use it. It's the ways that it can empower patients. And, I think about that. Earlier this year, I was on a podcast after the book was published. At the end of the podcast, the interviewer said to me, Dr. Pearl, you're a skier, you're a doctor. My husband fell skiing. He slid about 100 feet. His arm was up over his head. And it's now 3 months later, his shoulder still hurts. That arm doesn't work as well as the other side. What's going on? And I said, I think I know exactly what he has, but do me a favor. You said on the show you've never used ChatGPT. Why don't you go home, download the free version, put all the information in place, and let me know what the technology said to you, and I'll offer my thoughts on what I think it actually is. So 5 days later, she calls me back. She says, thank you so much. We put all the information in place, and it said he probably had a rotator cuff tear. It said he needed an MRI to establish the diagnosis, and he should see an orthopedic surgeon because he almost definitely needed a procedure done. Compare that to a Google search when you'd have 100 different reasons why a shoulder can hurt and 50 more why it doesn't work as well as the other side. And yes, it would tell you to see a doctor, not because you almost definitely needed surgery, but because that's how it protects itself. And they saw the physician. He said, you probably have a rotator cuff tear. He ordered the MRI. They knew exactly why he ordered the MRI. They knew what a rotator cuff was. And then after surgery, he said, if I'd waited 3 more months, I probably could not have gotten the tendon back to the bone because the muscle would have contracted. That is expertise. And as clinicians, we need to start asking, how are we going to empower our patients? And with them being empowered, what do we think they can do? And how can we be part of that solution, but not the whole solution, because we have to figure out ways that they can get care 24/7 at an inexpensive cost for them. That is where we are going. Higher quality, easier access, and greater affordability.
So bringing that to the point, then you're clearly a thinker, mover, shaker. Where is the business opportunity in this space? Because it's just moving. What is it that clinicians are supposed to be doing with this kind of technology to get ahead?
Well, there's really 2 ways to approach the business side. And I will caution clinicians that if they don't take the lead, others will. And that if it's led by the for-profit businesses and private equity, the results are not going to be what is best for them and for their patients. They're not going to be the highest priority of the companies or the investment agencies. So I think that that's the big piece that people need to be thinking about. So how might it be done? Well, I think clinicians can figure out, how can we change our business model, our economic model? As I say, to move from a fee-for-service into a prepaid, pay-for-value, capitated type model. And yes, it's going to require others to come along, whether it's the government or whether it's businesses. Whoever's paying the dollars are going to have to be willing to go along and make the kind of investments that are going to be necessary. How can we do that and then use the generative AI tools that are currently available? As I said, ChatGPT, Gemini, Claude, to be able to keep our patients healthier. And this is where I think that we will have thousands of articles published by every society and every journal. It's going to be 50% of the journals in the future if we take the lead, because we should share that knowledge, figure out the ways to accomplish it. In the same way we do with a new procedure or a new drug, this will be a new application of technology. But the alternative way is that companies will create, I want to call them bots. People like that word. I don't like that word. It's really just an application that we put a voice recognition software on top of, but bots that are going to be able to do the same thing for them. They will help the patient to manage their diabetes. They will help the patient to manage their hypertension. They will do these things for people rather than doing it for themselves, not empowering the patients. And of course, they're going to charge a lot for the services. And we'll be back into this, I'll call it a vicious cycle, where innovation and technology and medicine, rather than lowering cost, raises it. It's the only industry I can think of where new technology costs more, not less.
There's a powerful bit in there that you'd said with regards to the patients. And one of the ways as well, even in the practice of medicine, one of the ways that I have realized that this AI is going to work is at the moment, if you give me any patient under any specialty with my clinical background and AI, I can almost answer any question that they put before. It doesn't matter if they're cardiac, endocrine. I can then dissect what's going on in a way that we weren't able to do before. So that is extremely powerful. But it does seem as though it's going to have a direct impact on specialisms. How do you think that that is going to play out?
I think you're absolutely right that it's going to require, and I will say, more primary care and less specialty care, or at least the number of people in primary care versus specialty care. It will allow patients to get answers sooner, not later, when they need specialty assistance. And we're going to have to evolve the model. It's not that we have too many specialists today. It's just that we probably need to train fewer in the future than we do currently. You know, again, back when I was the CEO in Kaiser Permanente, and again, for people who are not aware of it, it's a very integrated organization with an insurance piece, a hospital piece, and a medical group providing the care. And it was paid on a prepaid capitated basis. We set up a system whereby there would always be a specialist available that primary care could call when the patient was in the exam room and the primary care physician needed a little bit more expertise to figure out exactly what to do. So we could solve the problem right there and then without having to schedule the patient to come back. Now, I think, as you're pointing out, it could easily happen with a technological tool once artificial general intelligence is reached, able to provide the same level of expertise. Because it's usually a small piece, as you say. It's not that you don't know anything about the problem. It's just that you don't know enough to be certain about what to do, so you send them to the specialist. Now, having said that, there's also a part of specialty that are the procedures. And this is, again, a place that I don't think we've done as good a job as we should do. And I know that, as I say, I do cleft lip and cleft palate. I probably did 1,000 surgeries. And I will tell you, after 1,000 surgeries, I was a lot better than I was when I'd done 2 or 3 or 4. And we tend, and this is more the United States, other countries like Switzerland, broad numbers of people doing all that I think they should get. So again, it's going to restructure what we do. It's going to allow patients to get, I'll say, higher quality with people who have more skill. We have to figure out how to train the next generation because the current providers won't continue to live forever. So we have an evolution. It's not that these things are problems that are easy to solve, but they're all solvable is what I would say. It's going to require we change medical education and we focus less on memorization, the Krebs cycle. What's the Krebs cycle? Well, that's the most commonly tested question out there. Why is that? Because that's our mark of the physician left over from 100 years ago. So the opportunity to make these adjustments, that will have to occur. But we should be looking at opportunities to figure out how to do things better. Interestingly enough, this morning I got an email from a woman who's responsible for the medical curriculum in a medical school. And she asked me, Dr. Pearl, you've written about generative AI, you've spoken about it. How should I change the curriculum? And in her mind, she was still thinking narrow AI. How do I teach them what it is, what the risks are and security and privacy? And I basically said, look, I can tell you that every student in your class will be using ChatGPT when they arrive. How do I know that? Because I teach at Stanford Medical School. And I asked the class the other day, how many of you use ChatGPT? And every hand went out before they make rounds, before an exam. Whatever. So you don't have to teach them how to use the technology, but you have to think to them about the application. There's a patient in your room with a particular chronic disease problem. How might you use it? You're seeing someone, you're not quite sure the diagnosis. How would you use it? Practice it. Put the information in place. Come up with the change and improved operative system. That is what we need to do. And I would encourage physicians at every point in their career to get involved. If not, it's going to be led only by those who are entering now, and they will displace the ones who are already in place.
This is exactly the question I wanted to ask you. Since you're a forward thinker, I take you back. Imagine that you had just finished medical school. You're saying your first year of practice. You see this technology coming along. What should you tell yourself to do at this point?
I would say I've got to get to the front of the pack. I've got to be able to use this technology to demonstrate superior outcomes. And if I can demonstrate superior outcomes, then I can be very successful in my practice. I don't know what it's like in Great Britain, but I can tell you in the United States, often affability comes in front of clinical excellence. And why is that? Because we truly don't know. How good is a surgeon, orthopedic surgeon? There's no data. You don't know how often their patients walked and were able to walk normally after surgery, after total joint replacement. You don't know how many infected hip joints they had. You don't really know very much about it. So do they have a good bedside manner, and were they friends with the primary care doctors? And I hate to get anyone to be skeptical, but did they send a nice Christmas present the year before? These are the kinds of things that often determine where the referrals went. And now we have that ability to be able to actually measure outcome. Did your patients with diabetes have fewer heart attacks or fewer kidney failures than people who someone else took care of? Because I want to go to the person who gets the best outcomes. And if anything, that might be a little terrifying, because we all in medicine have this fear that somehow we're not the best. We have to project the image that we are. What do the results look like? To some extent, they've been easier if you look at something like my specialty, cleft lip and cleft palate, because everyone can see it. But when it comes to most of the procedures that we do, impossible to know. And certainly when it comes to things like heart surgery, the data should be there, but it's not available that certainly the typical patient can find.
And when you think about the patient, you're talking to your niece or your aunt, the aunt or uncle, and they have access to a smartphone, they have ChatGPT. How should they be using this technology at this point for their health?
Well, the first thing I want to warn them is every time you put information into ChatGPT, pretend that it's not you. There's a take your aunt. There's a 54-year-old woman having the following problem. What would you tell her to do? The fact that it's you want to put that in an anonymous kind of way. And we've had a lot more time. We could talk about all of those concerns, but that's the first thing that I would say. And the second thing that I would say is become an educated patient. Before you see the physician, make sure you've researched it as best that you can. And it's not like a Google search where you have all these links and you can't figure out what's accurate and what's not. And you go in with 100 pages of ideas, 70 of which are foolish or self-serving. This is not a technology supported by advertising. This is a technology that has read every medical journal, read every medical textbook, and can educate you so that you go in as an educated individual. You're not a doctor, but you have to be an educated consumer. Spend as much time learning about the problems that you have as you might if you were researching the purchase of a new product on Amazon.
As I listen to you and I hear the passion, where did it come from? What in the world happened to you that got you on this path with AI?
It came out of the work that I had done in healthcare and my recognition that we have opportunities that we don't take advantage of to be able to save human life. This is why I went to medicine in the first place. As I said, it came out of my problematic experience in college and other pieces reinforcing that. I'll call it negativity that would have been out there. I could see it again in Kaiser Permanente. We lowered the chance of patients dying from a heart attack by 30%. We lowered the chances of someone dying from colon cancer by 40%. We had opportunities to be able to do these things. And yet I recognize that, you don't have to be wealthy to belong to Kaiser Permanente, but you had to be working, you had to have a job. It was a different situation. And I said, well, how can we do this everywhere? That's sort of why, after being the CEO for 18 years, I left and started doing these things at a national, international level, because I wanted everyone to be able to have that opportunity to have a 30% greater chance of being there when your kid gets married or graduates, or whatever the outcome would going to be. So my first book, as I said, was called Mistreated. It looked at the systemic problems, the fact that medicine is unorganized, doctors scattered across the communities, not communicating with each other, care uncoordinated. It's paid, as we said, on a piecemeal basis. The more you do, the more you get paid. Whether there's any good or not doesn't matter. It's not measured by that. We use actually outdated technology in the United States. The most common way that doctors communicate is the fax machine. It's an 1834 invention. My students at the business school ask me, what's a fax machine? They've never seen one. And there's no way to make change happen. And Great Britain's a little bit better. Again, I know a moderate amount about that. I know about the various hospitals, trusts, and the connections between them and the different pieces that are there. But it's still not as well driven and organized, even though it has a government sponsor sitting above it. But I wrote about all the challenges and opportunities. And then I realized, no, the system is not enough. And so I wrote my second book called Uncaring: How the Culture of Medicine Kills Doctors and Patients. The things that we learned in medical school that are so far outdated, the ways that we learn to treat patients, the culture of medicine, the hierarchy we have as to what's important and what's not. And I still realized after all that time that as much as the system had to change, the culture had to evolve, that we didn't have a tool capable of having people do it, because the cost of using humans to do all these things was beyond that which any nation in the world could afford to do. And then all of a sudden, November 30th, 2022, this tool comes out. And of course, as I say, I'm interested in technology, so I'm always trying things. And I try it, and it's amazing. I said to my wife, you got to try this. And she says, oh, Robbie, come on. You're always wanting to talk about technology. I said, just try it. And now, we're using it every Sunday night. We say, okay, we want to eat dinner this week. We'd like menus. We'd like shopping lists. We had a weekend where we ate a lot of food, so make it a little bit lower calorie. And here's our budget. And it'll print it all out for us. It is so dramatic an opportunity. I gave a conference the other day, the primary care conference in Washington, D.C., and the person interviewing me said that he spent 4 hours coming up with questions. Then he asked ChatGPT, what should I ask Dr. Pearl? And in less than a minute, it gave him better questions than he had come up with. We are just sampling what exists today, to say nothing what's going to be here in 5 years. So the excitement you're hearing is that what I've dedicated my life to, which is improving the health of people, saving lives that had been difficult, is now going to become easier. And rather than seeing that as a problem, I see that as a positive, because ultimately that's why people choose to become clinicians in the first place.
Wow. Listen, that is some real passion, inspiration. I'm going to make sure as many people as I can listens to this conversation, because something about the way you captured it and the way it's linked to your general passion in terms of your surgery and your mission to help people somehow came across in a very powerful way. I think this is very important. So we're going to be closing out now, Robert. What I want you to do is that I want you to think about two groups I want you to speak to. One, clinicians, doctors, and so on, or even the healthcare system. And two, to individuals. If you had to condense these thoughts about AI into something that they can take away, how would you do that?
I would not try to convince them to do something. I would let them convince themselves. For clinicians, what I would say is, you're going to need to have confidence in the reliability of these tools, because the worst thing for a doctor ever is that you do something that harms a patient. We take an oath not to do that. So I want you to use the application and ask it some questions. First, ask it from the perspective of the patients you saw today. If they had used the application and come up with answers for the diagnosis and for the treatment, would it have aligned with yours? And if it did, that's great. And if it didn't, maybe why not? And how can you get better at doing that? And then the same thing for yourself. Ask yourself, how could I use this if I was seeing a patient with a complex disease to establish the right diagnosis? In the United States today, 400,000 people die from misdiagnoses. Another 400,000 people are permanently disabled from misdiagnoses. This tool can help us to accomplish that, to say nothing about the management of chronic disease. So reliability, I think, is what the clinicians have to experience, because once they understand how reliable it is, they'll figure out the applications in their own practice. And for patients, I would say, do the same thing. Again, remember to make it anonymous and see the advice that you were given and compare that to the advice from the clinician, and ask yourself, if I had known all of this before I went to the doctor's office, could I have explained things better? Could I have gotten a more accurate answer? Could I have been able to ask better questions? Is this a tool that is going to help me to achieve better health for me, my family, the loved ones around me? And I'm confident that as people experiment with it, and maybe it's not now, maybe it's a year from now or two, when it's 2 times better or 4 times better, they will start to figure out how they can embed it in their life. You know, I have a monthly newsletter called Monthly Musings on Healthcare, comes out the second Tuesday of every month. And I asked people about it a year ago. When I asked them, about 25% of people were using it. My most recent survey, 75% of them were using it, and over 90% said it was both reliable and useful, with less than 2% saying it was in any way problematic or inaccurate.
Beautiful, beautiful, wonderful. Listen, as I said, that there is a passion that you have on this that is contagious. And it is something that is also very empowering. And so I want to personally encourage you to continue to raise the voice, bring the challenge, because more than ever, I think people need to hear this, reflect on it, and work out how they're going to use it in their daily lives. Thank you very much, Robert. Really appreciate you spending the time, and look forward to hopefully interacting in the near future again.
Can I add 2 things at the end?
Sure, yes.
What I will promise people is that the dedicated clinician with the empowered patient and generative AI will be exponentially greater than the success and effectiveness of any of the 3 alone. Don't think about it as one or the other. Think about it as the triad, as the combination that's there. And as I said, I have a website, robertpearlmd.com. And as listeners and viewers figure out how to use this technology, send me a message. I want to learn from you. Together, we can make healthcare better across the globe. Thank you for having me today. Thank you for hosting this wonderful podcast.
Beautiful. Thank you very much again, Robert. And I will ask you to wait with me for the outro. Thanks again. Have a great afternoon and evening.